In the
Okay.
meantime, while everybody's joining, I got a couple questions. So for you, Dr. Blanton, and we'll get your answers before we get started. But what you thinking about what's something as a misconception about TMD or sleep that you wish every dentist understood? What would be one thing that if it would just everybody knew that you think it would make life better? And then the other one for you would be, if you could go back to your first year treating sleep TMD, what's the one thing you wish you could tell yourself now? And now I know all the attendees are thinking the same thing. Like, man, you've learned so many things. What's the one thing you would want to learn or tell yourself? It's a good one.
Okay.
And I'll throw some out to the attendees that are still arriving. We're up to 20 now. Attendees, do you primarily treat sleep or TMD in your practice or both? And my favorite question I always ask is of sleep and TMD, which patients keep you on your toes more, TMD or sleep patients? Or the combo patient? I guess that one would be pretty keep you on your toes for sure. And just a reminder while we're still getting ready, the chat box will be for chat for everybody, and then there's the Q&A box. Make sure we use that for questions so that way we can filter through and make sure we get to everybody's questions throughout the webinar. TMD.
And I want to say hello to Dr. Mitchell
Yeah,
and,
absolutely.
and to Danielle and Avery. They were, we worked together.
Oh, fantastic.
Dr. Mitchell now owns my practice, and Avery and Danielle run it.
That's fantastic. Got the support here. TMD. Oh, they're saying hi back to you, Dr. Blanton.
Okay.
All right, we'll give it a couple more minutes, get everyone logging in. We're still filling out questions again for the audiences. I have Elizabeth Mitchell said it was TMD patients. Are TMD or sleep patients keep you on your toes more? I don't want to say difficult, keep you on your toes. What do you guys think? TMD, 100%. TMD. I think we might have a winner already.
Hmm.
Well, while we're still waiting, Dr. Blaine, maybe we can go back to your first one. So, what's the one misconception about TMD and sleep that you wish every dentist knew?
Um, I think that first of all, not to be intimidated by the temporomandibular joint. It's pretty much like any other joint. There are some differences to it, but it's not a mystery joint um, like we kind of thought in school. Um, there's a lot more known about what's actually going on with that joint. So there are some differences than from other joints, but it's pretty straightforward, and it doesn't take a lot to. If you just are a critical thinker, you can figure things out for a lot of the patients.
Right. So, don't overcomplicate it.
Right, right. Don't be intimidated by it.
Don't be intimidated by the joint. I don't know. It's after going to a couple conferences and different speakers and lectures now, I get why it's intimidating. Tough scares me every time I go. I'm like, what are we talking about here? Right. Anyone else agree with Dr. Blanton? You think we don't be intimidated by the joint? Is that the overall response from everybody? Yes. Daniela Grimes. Yes. I guess I got to do a little more studying, Dr. Blanton, so I can make it not be as intimidated by the joint.
Okay.
Well, Elizabeth Mitchell wasn't really taught about TMD well in dental school, sadly. I hear that a lot about sleep and TMD. It's not really covered in the schooling. So I get it. That could make it intimidating, not having any clinical on it or any experience. That can definitely make it tough. That's why Dr. Bland's here. We're going to talk about it.
Uh,
We need two attendees. We'll give it about 1 or 2 more minutes, Dr. Bland, then we'll let you get started and get those late
okay,
people rushing in, trying to log in at the end of the day.
right.
Starting to see a lot of familiar names in the chat too, which is awesome. Glad to see everybody come back. First time people as well. Looks good. Good. See Jeff Sullivan in there. Got a shout out to our sales rep. Got to say hi to Jeff. I think we're probably pretty good here. I'll go ahead and start with a disclaimer and kind of do a welcome, Dr. Blanton, and introduce you, and then we'll get it started. Does that work for you?
Yes, sir.
Excellent. All right. Well, just to let everybody know, this webinar is for educational purposes only. It's not a substitute for professional training, clinical judgment, or individual patient care. Treatment decisions should always be based on the clinical evaluation and patient-specific needs. Just a little caveat so we all know that this is an educational piece. So we'll go ahead and get started. So good evening, everyone. It feels like it's still afternoon here in California, but we'll say evening. Welcome to the True Function Monthly webinar series. We really appreciate all of you taking the time to join us today. Thank you, Dr. Blanton, who I'll introduce in a minute, for joining us and speaking for us today. You know, our goal with these webinars are very simple. These sessions, it's what's working in the real world, right? Where's that experience? Where's that education? And just being able to share that and creating an environment or a space that allows these communications and chats and webinars and question and answers. So this allows us to, go everything from clinical to business strategy to, centering around helping treat your patients better and help build your practice. And we have all these on our YouTube site and our website. So if you ever want to go back and look, we're here to help and be that advocate and create this environment for us to be able to share this information. We're excited to have Dr. Blanton here today. Want to remind everybody that keep your cameras off and microphones will be muted. Today's session will be the speaker view for Dr. Blanton. The chat box can be used for chatting or just having things to talk about. The Q&A box you'll find at the bottom will be where you can submit your questions and where you can make sure that we go through all the questions that you have, either for myself at True Function or for Dr. Blanton for his presentation. So again, the chat box is for chatting and the Q&A session box is making sure that we get our questions answered. So for those of you joining for the first time, welcome. Thank you for joining. Anyone returning, it's great to have you with us and joining us and helping build this environment and culture that we have at True Function. True Function is a medical device manufacturer that's based out of San Diego, California. We focus on sleep apnea and orthodontic occlusal type guards and devices. But what we do goes far beyond manufacturing devices. For more than 25 years, True Function has existed to help make the clinician's life easier. That's how Frank started this. He was a dental assistant and a CDT, and we really want to make things easy, not only for you, but for your patients. So we've really built a reputation around these tried and true, delivering consistent quality, friendly and personalized, treating doctors like partners and being loyal and intentional because we stand behind our work and our word. So this is just part of what we do, is not only manufacturing, but being a part of this community that's grown for over 25 years now with Frank at the helm. So through our webinars and educational programs and day-to-day collaboration, we've really built a space where clinicians and technicians work together to really push patient care forward and help grow businesses and see success for all of you who are attending. So, we're a partner built on precision and trust and really committed to helping you and your patients' lives for the better. So it is my pleasure to introduce all of you to Dr. Alan Blanton, our speaker this evening. Dr. Blanton has spent his career changing the way dentists have understood sleep, pain, and the joints, patient care altogether. He graduated from the University of Tennessee College of Dentistry, became a diplomat of the American Board of Dental Sleep Medicine, and went on to lead the Dental Sleep Medicine and Oral Facial Pain program at the University of Tennessee Health Science Center. After 25 years in general practice, Dr. Blanton shifted his entire focus to dental sleep medicine and oral facial pain and TMD. Since then, he's lectured across the country, served on the AADSM board of directors, led major AADSM programs, and continues to guide his former practice Mid-South TMJ and Sleep Apnea Dental Treatment Center as an advisor. He brings a mixed, deep expertise and real-world clarity to that makes complex topics easy to understand. Today, we're going to explore how sleep and pain connect, why it matters, and how adding TMD and oral facial pain into your workflow can open the door to better outcomes and real practice growth. So please join me in welcoming Dr. Alan Blanton.
Thanks, Eric. You want me to go ahead and share my screen now?
Absolutely. If you want to start sharing your screen, and then if we want to get your other answer, if there was one thing that I asked you earlier, one thing you could go back and tell yourself the first year, what would you tell yourself now as your younger self?
That I would have spent a lot more time understanding orofacial pain. We tend to kind of boil it down to just the joint, and it's so much more than just the joint. But just understanding orofacial pain and going ahead and starting to incorporate that knowledge into practice early on. I would have a lot sooner geared myself towards doing orofacial pain and sleep full time as opposed to trying to work it with the general practice. And what's required there is really building your physician network, your sleep clinic network, your network with the nurse practitioners, with the sleep centers. And if you do that, if you spend the right amount of time and energy, you can really build this practice into something that is really sustaining for you. So I would have focused a whole lot more on building that practice right when I first started.
Absolutely. I will keep that in my back pocket when I talk to new dentists, letting them know, go all in, talk to Dr. Bland. He'll show you the ways. So, well, I won't hold you up anymore, Dr. Bland. The floor is all yours. I'm going to mute and get off camera here. But if you need anything, just shout out. And thank you again for being here this evening.
Sure. Thanks, Eric. So what I wanted to talk with, and I'm gonna try to keep my eye on the clock here, so that I don't bore people with it. But what I wanted to talk about was trying to instill in folks that are doing oral appliance therapy for sleep patients into getting more knowledge and understanding about orofacial pain and what they can do to treat those patients. Because what we find out, and just to clarify, I'm retired now. My practice is owned by, my former practice is owned by Dr. Elizabeth Mitchell in Memphis. And she's continuing to grow this practice, and she's done such a great job at continuing to grow the pretty conservative physician network that I had by reaching out to ear, nose, and throat otolaryngologists, reaching out to internal medicine physicians who screen for sleep and test and treat sleep patients with original PAP therapy, or the normal PAP therapy kind of things. So that's who runs that practice now, and her along with Avery, who's her primary assistant, chairside assistant in that, and Danielle, who is her coordinator for the patients and dealing with the medical insurance. They've got a good sustainable practice that they're building, continuing to build off of what I started. So that's where we are with that. Let me see and make sure I'm getting over here. Let's see. There we go. Okay, so why would you want to incorporate uh, orofacial pain into your dental sleep practice? Well, there are going to be patients, and they're not going to be a bunch, but there'll be some patients that will have treatment emergent TMD and oral facial pain issues when you put them in an oral appliance. That's not that's something that I think tends to concern people initially when they're starting out in dental sleep, and it shouldn't be. They're usually those type of things are usually pretty self-limiting and pretty short-lived if there is a problem that develops, and they're easily manageable. There's also, it's been proven that there's a strong correlation between sleep-related disordered breathing and oral facial pain and TMD, people that have initial onsets of TMD. Many of the sleep-related patients, disordered breathing patients are, of course, as we all know, are undiagnosed. There are a bunch of people walking around out there that are not being diagnosed, not being treated. That's what we need to be concentrating on. And very few dental offices, provide what I would consider adequate oral facial pain treatment. There are a lot of practices out there. I'm going to show some statistics. There are a lot of practices out there that say they treat TMD or TMJ or temporomandibular joint problems, but pretty conservative treatment, and we can do a whole lot better with more understanding. This all goes back to in 2017, the House of Delegates, developed with a lot of input from the American Academy of Dental Sleep Medicine, that dentists are now encouraged to screen patients for sleep-related disordered breathing problems, and then they issued a policy statement, kind of outlining the role of dentistry in the treatment of sleep-related disordered breathing. If you look at the numbers, when we look at the total number of dentists in the United States, and these are the best figures I could get, this goes up from comparing 2023 to 2024. Well, a slight decrease in the number of dentists nationwide, but that's because a lot of us are baby boomers that are hitting retirement age. And there's not a shortage of dentists. There's just a different dispersion of age groups that are in dentistry now. So a lot of the older folks are hitting their final years or in retirement. But if you look down at the bottom there, the number of dentists and specialties, and remember that the American Dental Association made oral facial pain a specialty back a couple of years ago. Really, according to the ADA their data, there are only 72 dentists in the nation that really run what we would consider an oral facial pain practice, where they limit their practice basically to oral facial pain. And some of the ones that I know that do that really are not that big into sleep. A lot of them are, but others are not, which is kind of interesting to me. But this is a wide open field. In 2024, the American Board of Oral Facial Pain listed that they had 287 diplomats in oral facial pain. So this is a real wide open field that people that deal with the sleep patients really ought to pick up on getting the training for, to feel competent to start to treat these patients. Here's some interesting statistics, and several of these are from 2019 and 2017. I think they were the latest figures that I had. But one major ortho appliance laboratory reported the following: that despite that guidance in 2017, only 20% of their clients at the dentist who prescribed their oral appliances ordered appliances to treat obstructive sleep apnea. This was back in 2019. I'm sure the numbers increased a little bit, but my observation is it's not greatly different. So that's pretty amazing. And then less than 1% of those clients accounts prescribed 10 appliances or more for the year. And I recognize that fact in talking with a lot of dental practices that a lot of dentists that will list on their website that they treat sleep, they they do, maybe an appliance a month, at the most. And that's, again, there's just this really unfulfilled need for um, patients, prescribers to be treating sleep. And as we're going to go forward, I'm going to talk about how we incorporate oral facial pain into that statistic as well. Um, Inside dentistry, there was a survey that discovered that 38% of the dentists that were surveyed offered oral appliance therapy for obstructive sleep apnea. But only 5% of those surveyed dentists treated more than 5 patients a month. So again, the numbers are really low for the vast majority of dentists who have some training in sleep. Maybe it's because they haven't really built their physician network or their referral network. Maybe it's because of other reasons. Who knows? But that's the statistics that we have. Frost and Sullivan, a marketing research firm, did some research and understood that out of approximately 200,000 dentists in the United States, 100 dentists account for 34% of all the oral appliance therapy cases, which is kind of amazing when you think about it. Just 100, and I'm sure that we all know some of those individuals who have huge oral appliance therapy and dental sleep medicine practices, but there are very few across the country. There's another lab that uh, showed that that out of 2,000 active prescribers, 2,000 active dentists, less than 200 or more, less than 200 prescribe more than 20 appliances a month. So DMS providers, which the primary source of DMS or DSM, dental sleep medicine providers, are in general practice as well. And the vast majority of them prescribe less than 2 appliances a month based on this other lab's statistics. So we've got a lot of oral facial pain patients that have an underlying sleep disorder breathing condition. And that group has really been ignored or totally undetected in the past. What we all know is that many female patients don't present the same way as males do. Males are pretty easy to pick up on. Males that are overweight, that have large neck circumferences, that are older than 50, you can almost bet they're going to have some sleep disorder breathing, and they're going to be a primary source for looking at some type of therapy, whether it's oral appliance therapy or a PAP therapy. You'll have a lot of those patients that come in that are already on PAP therapy or have been told to be on PAP therapy or been diagnosed, but there are a lot that have not been diagnosed. So that's always a group you want to be cognizant of when they're coming in the office. But many female patients are really unaware that they have a problem with their breathing at night. They don't. A lot of times they don't really snore, or they don't get reported that they snore, and they don't have this indication of a real breathing problem at night. But a lot of those patients will come in complaining of oral facial pain complaints, which is really interesting. And a lot of that's due to just the physical anatomy, the oral and pharyngeal airways, that result in not only the breathing problems, but also the oral facial pain problems. So the statistics that we have is 22 million Americans suffer from obstructive sleep apnea. It's probably more than that, a lot more than that. And at least 80% of those have gone undiagnosed. We also have statistics from the oral facial pain academies that 35 million Americans suffer from some type of TMD, oral facial pain symptoms. So when you have an oral facial pain patient that comes in to your office complaining of joint problems or just facial pain, muscle myalgia, those kind of things. Well, the first thing you want to do is you want to try to manage the pain, obviously, and you want to educate the patient on what's going on. And there we have a lot of different implements or mechanisms that we can use to treat or to educate patients, showing them the anatomy, showing them how the joint itself works, and those kind of things. But you also, particularly when you see signs and indications, when you look orally at the patient of the possibility for sleep disorder breathing, whether it's signs of bruxism or crowded airways or scalloped tongues, those kind of things, you want to always discuss that patient's sleep and just their history, how things are, and you want to get them referred for an evaluation, which hopefully will include testing to see if they in fact do have an underlying sleep disorder breathing problem. You can consider a temporary appliance. A lot of offices do. I know that there are even ENT offices that when they suspect there's a sleep disorder breathing problem, they may even prescribe a temporary appliance. We have that in Memphis where we were. We had that occur occasionally with one or two of our ENTs. In general dental practice, the most common treatment for TMJ is a night guard, and we all know that. I mean, that's kind of what we learned in dental school, was to throw a piece of magic plastic in there to see if that would help the patient. And a lot of times, that may give some relief. It's not night guards are not a bad weapon to use, but you need to have more arrows in your quiver than just a night guard for patients that come in complaining of joint pain or orofacial pain symptoms, muscle myalgia, headaches, those kind of things. So there's another statistic. A well-known major dental lab reports that they've produced over 10 million preventive oral appliances over the last 25 years, and 70% of those appliances are night guards, just standard night guards. So that just kind of tells you that the most common way of dealing with any type of orofacial pain complaint or TMJ complaint is to throw a patient into a night guard. And look, I did it. I've done it. We all have, but night guards maybe not always the best solution. We know that, particularly if we haven't done our due diligence and determined whether or not we have a concern that the patient may have some sleep disordered breathing, if we just throw a night guard in and increase the vertical dimension, there are several studies out that show that by doing just increasing the vertical dimension without stabilizing that lower jaw or protruding the lower jaw any, that we have a risk of aggravating their sleep disorder breathing for many of these patients. So that's not a good thing. And that's something that we need to be aware of. About 74% of patients with sleep apnea and 40% of patients with insomnia report having headaches in the morning. And we might wonder why that is. Several studies looked at this, like this one study this was by Canuli, that they wanted to evaluate the prevalence of pain associated with TMD in sleep apnea patients referred for oral appliance therapy, and the numbers of 87 patients between ages of 18 and 65 with that were diagnosed with sleep apnea. What they found was that 52% of those patients presented with symptoms of TMD. The most common orofacial pain problem that they presented with was myofascial pain, or pain in the musculature of the muscles of mastication. So the conclusion was there's a very high prevalence of TMD or oral facial pain in patients with obstructive sleep apnea, and they require more of an understanding of what's going on than just um, seeing them as obstructive sleep apnea patients. You can use in your practice, which they did in that study, the RDC TMD screener, which is just a 2-page form that's presented to a patient, usually at probably a hygiene appointment, especially for new patients coming into the practice, but as well as doing this for existing patients, doing some type of screening or at least asking questions of the patient. And you'll even find that sometimes you can see a very healthy patient, female patient in your chair that may your hygienist may feel a little weird questioning them about their sleep. A lot of them do have problems, but even if they don't, a lot of them may end up saying, and this has happened before, that, hey, I don't think I have a problem with my sleep, but my husband sure does. And that's just an avenue for, following up with the husband, getting them in and having them evaluated for sleep disorder breathing. Because it is much more prevalent, at least under the age of menopause, it is much more prevalent in males than it is for females. We know this. The Opera study, cohort study, the oral facial pain prospective evaluation risk assessment study also concluded that there's a high probability of obstructive sleep apnea associated with oral facial pain or TMD. And so that's just another study that supports this idea that when you see a patient that may be referred to you for sleep apnea, you also need to question about any oral facial pain issues, TMD issues, and conversely, any patient that comes in complaining of TMD issues or oral facial pain issues, you need to evaluate them too for the obstructive sleep apnea, because many of them, it's related to their sleep disordered breathing. So the question you need to ask yourself when you see a patient that's in your chair complaining of TMD, TMJ, or oral facial pain complaints is this just simply a TMD patient, or is there a possibility of sleep-related disordered breathing that you need to uncover? Gilles Levine, who up at the University of Montreal, says this, that in the apneic patient, it's believed that the jaw opening and jaw clenching muscles, when they're activated, which we see in sleep bruxism, that it could possibly be occurring to prevent pharyngeal collapse, keeping those pharyngeal dilator muscles more active during sleep in order to maintain the airway. So evidence of bruxism, according to this paper back in 2015 and still today, evidence of sleep bruxism where it's by report or what you see clinically with the patient, it should always prompt you to test for abnormal breathing during sleep or sleep disorder breathing. So a lot of times patients will complain, their major complaint may be headaches in the morning. And why would that be associated with bruxing or an underlying sleep disorder breathing problem? Well, the patients with obstructive sleep apnea are at a high risk for sleep bruxism, and more of the research is showing this relationship between sleep bruxism and obstructive sleep apnea. And it's suggested that what we call a parafunctional habit, or what we were taught in school and what we've always understood it being a parafunctional habit, may actually have some protective function to it in the patients with sleep apnea who have airway collapse. Again, shown through studies. 30 to 50% of adult patients with sleep bruxism complain of headache either in the morning, most frequently in the morning, or during the day. Why is that the case? Well, when you have obstructive sleep apnea, we know that there's a decrease in the oxygen saturation, there's an increase in the carbon dioxide. And what that does is has been shown that it increases the genioglossus and masseter muscle activity when we have these airway collapses. So that increasing the masseter muscle activity and genioglossus activity is what we see with patients that brux with this repetitive masturatory muscle activity. And because of the oxygen decreasing, that may be the reason that we see the headache. So the role of the intermittent hypoxia when the oxygen level is dropping and carbon dioxide is rising during the night for patients that have sleep apnea. It's that the hypercapnia and the sleep fragmentation may be the actual cause of the headaches, this decrease in the oxygen and the increase in the carbon dioxide. What's great and works in our favor is that in treating options for both sleep disorder breathing and TMD orofacial pain complaints, a lot of times, one of the primary ways of treating that is oral appliance therapy. So there are a lot of times we can kill two birds with one stone with oral appliance therapy in these patients, and we'll talk about that in a minute. Again, plenty of studies talking about bruxism and its contribution to problems that the patients incur at night. And remember that sleep bruxism is a sleep disorder, just like oral obstructive sleep apnea is. It's something that we as clinicians can diagnose, we can observe, and we can offer treatment for. So understanding more of what's going on and reading more and studying more about sleep bruxism and its relationship to obstructive sleep apnea is a great way to increase your knowledge about how to pick these patients out and offer them a treatment that's helpful to them in decreasing improving their sleep as well as decreasing the pain that they may be experiencing that's related to it. So again, studies like this are things to look at and understand. Sleep bruxism can only be diagnosed through a sleep study, just like obstructive sleep apnea can when they put the probes, the electric probes on the masseter muscles and on the mentalis muscle to pick up these signs of the sleep bruxism. Otherwise, what you see in clinic when you're looking at a patient, you may see signs of bruxism where the teeth are ground down and the wear facets that you see, but you can't distinguish if that's due to clenching and grinding during the day, probably related more to stress, or is it something that's a sleep related bruxism issue, which can be a lot of times related to sleep related disordered breathing. When we evaluate patients, you need to come up with a kind of a routine way of addressing these issues. Otherwise, you'll find yourself sitting in front of a patient who will tell you a long story about the issues that they have. It'll be really difficult to pin down exactly what the issue is. So you can use the Socrates evaluation where you question about the site of the pain, when it started, to describe the character of the pain. What's the pain like? Is it dull? Is it throbbing? What is it? Does it spread, the radiation? What makes it feel better? What alleviates the pain? When is it worse? Timing. Is it worse in the morning? Is it worse at night? What makes it worse? Does chewing make it worse? Does talking, what chewing gum make it worse? Those kind of things, and then ranking the severity of it. So that's one method you can use to go through and ask questions related to that acronym to kind of pinpoint what the issue may be. Another is the OPQRST evaluation, where again, you're asking about the onset of it. The P relates to what palliates the pain, what makes it better, what provokes it, what makes it worse. The quality of the pain, is it throbbing, sharp, stabbing? What is it? Radiation, where does the pain radiate from the site of the pain? How severe is it? And again, the timing of it is worse in the morning or the afternoon or the evening. So why do we even have these problems like disordered breathing at night, and these oral-facial pain problems? Have we always had these, or is this something new? And what we get into in the big line of study now is the epigenetics of the origin of sleep disordered breathing and oral facial pain issues. So epigenetics is things related to the environment, the lifestyle, the habits, and how they play a role in problems and disorders that we encounter. We've had a lot of huge changes to the facial anatomy, actually pretty recently, since the industrial age. So the industrial age was back in the 18th century. It was the time when a lot of inventions were occurring. People were moving into urban environments. They were not living out in the rural areas. Their diets changed. As we started to cook our foods and change our diet, our foods got softer. There was less need for chewing. Lifestyles changed. Even particularly in industrial age, infant nursing periods changed because more females were entering the work pool, so that they didn't have the time to be at home to care for the children, and long time nursing of babies. We started having bottle fed babies just to make life a little easier for everyone, particularly because everything sped up during the industrial age. So I remember when I was a kid, and when I first got interested in dentistry was in 7th grade. My sister was going to dental hygiene school. She was 8 years older than me. She was going to dental hygiene school, and she and her partner did a research project on the Native American skulls and that were at an Indian village that was in downtown Memphis, in Chucalissa Indian Village, and that they used to have. They no longer have it because they gave all the skeletal remains back to the Native American tribe, and they were buried. But they used to have them on display, and it was really interesting. I remember them taking pictures and doing this whole research project about the changes in the skulls and particularly in the teeth of Native Americans compared to modern people. And back during the more ancient times, prior to the Industrial Revolution, even a little prior to that, when we were hunters and gatherers, we used our jaws and our muscles of mastication more. So we had really large masseter muscles. We had, let me see if this changes. I think it will. The things that you see is the whole lower third of the face kind of receding posteriorly. Teeth become crowded. The muscles become less large, less used, so they atrophy a little bit. I'll see if I can go back and do that. So again, you see the change from the hunter-gatherers to now modern man. It's not significant changes, but it is when you look at it closely. So when you look at the different skulls, what you see is the hunter-gatherers, the more ancient peoples, they had all 32 of their teeth. They didn't have to deal with impacted teeth. They didn't deal with crowded arches. They had bigger jaw bony structures, larger mandibles, thicker muscles, because they had to chew their food more. There was more involved in masticating food than there is now as we've become more softer diets. And of course, on top of that, we've introduced refined sugars, complex carbohydrates. We've got a lot more decay. They didn't used to have decay back in when you looked at ancient skulls. So what you would see is with more ancient man, fully formed arches, all 32 teeth, large nasal airways in the palate, posterior palate, easy to breathe. Now, since this is showing the 1940s, you can see much narrower arches we deal with, crowded teeth, periodontal disease because of our diet. And these are all basically dietary changes is what it can be attributed to. And in that also with the narrowing and then we're not using the muscles like we used to. Now we've got narrowing of the nasal airways. So we've got more problems with breathing, more problems with masticating our food, keeping our oral hygiene correct and those kind of things. So this is what keeps the periodontist and the orthodontist and the endodontist in business. That's what's happened to us. I'll go quick through here. I mean, not only if we move the lower jaw back, we also change the angle of closure at the joint. We've got the smaller musculature. Everything changes. So you go from this really nice, fully formed arch in the hunter-gatherers with all the teeth present to crowded arches, constricted arches, impacted teeth, misaligned teeth, and we understand how even pushing this, everything going back starts to crowd the airway with the base of the tongue. And so that's why we see some of the problems. I'm going to jump through this just out of respect for time, but we can even see it in some of the even modern day in like the Australian Aborigine tribes. These changes because of diet changes, what's happening. Really interesting books if you want to look some of this stuff up and read about it. That while the teeth can certainly be straightened when we have these crowded situations, we really need to look at why we're running into these problems. And our jaws are getting smaller, our teeth are more crooked and crowded, creating not only these aesthetic challenges, but also difficulties in breathing, swallowing, and TMJ function. So there's something to understand. We'll see more epigenetic changes, and the next one that is predicted is because of cell phone use, that more people are in this position too much. We already know people that are having problems, carpal tunnel problems with their hands because of using their hands on their phones, this forward head posture. None of this is good and will probably express itself years on down the road in these epigenetic changes that we see. So when you have a patient come in with pain, it's always helpful to rather than them say I've got pain on my left side of my jaw, for them to actually take a finger and point to it, because you want to determine, are we talking about an actual TM joint problem or are we talking about a muscle problem? So one of my mentors, Dr. Jeff Okeson up at the University of Kentucky, he always told us, remember this when you're assessing a patient with pain. First, you want to rule out the teeth as being the problem. So do you have decay? Do you have an abscess? Is that what's causing the problem? If it's not, if you rule out the teeth as being the source of the problem, then the next thing you want to look at are the muscles. You want to do a good full masticatory muscle palpation to find out if it's muscle tenderness or myalgia that you're dealing with. Once you ruled out muscles, then you think about the joint itself. More often than not, it's going to be muscle problems. Then it could be the joint. And then you can start thinking about some other weird type of facial pain condition like Eagle syndrome or something like that. But those are very, very rare, those type of things, issues. So don't immediately jump to that you've got some kind of rare zebra condition. You can read about understanding it's helpful with this infill when you're trying to separate the teeth when a patient comes in and they're kind of locked, they can't open wide, they're restricted, they hurting. If you press against the teeth and try to open them, if they open a little bit, you're probably dealing more with a muscle issue. If they feel kind of rock solid and there's a hard end feel to trying to separate the teeth and then open any further, then you're probably looking at more of an internal joint disorder, probably like a non-reducing disc displacement, where they can't, their muscles will not let their jaw open anymore because it's too painful. So that's kind of a one way of helping to determine if it's a joint problem or a muscle problem off bat. Excuse me. Just the fact that the way that we're born, that affects a lot of different things with us. These epigenetic factors have resulted in the decrease in the mandible, the masticatory musculature, as well as posterior position of all the structures. And that force of angulation of the masticatory muscles and condyle position may play an important role in the development of TMJ, TMD, and orofacial pain issues. So there is the possibility of using a mandibular advancement device may develop TMD in a small number of patients. It's usually pretty transient, short-lived. The symptoms may decrease over time. You need to be aware that what the issue is if you do create a problem for a patient. And again, when I first started out, we used to right off the bat advance people 70% of their total range of motion. Towards the end of my career, got completely away from that. The literature showed that just an increase of 50% for the vast majority of patients will make a significant decrease in the amount of sleep disordered breathing. So it became pretty common for us to be our initial starting position was 50%. So if a patient could go back 5 millimeters and go forward 5 millimeters, then we would start them right at 0, which would generally be end to end. So that's where we start a lot of patients is, right at end to end, maybe just a little forward of that, but basically 50% of their total range of motion from protruded to retruded. And you really don't run into the problems of creating problems for them. 20% of the patients are going to develop some type of posterior open bite, but 1 out of 4 of those patients were even aware that there was a bite change. We would see it. And that's why we all started doing AM positioners or morning positioners on patients to help reestablish that initial bite on the patients once they came out of the appliances. And that, I don't know what the statistics are, and I don't know if there are really any studies on it, but just from an anecdotal standpoint, when I first got into this, we were not doing AM positioners. I really think in just my clinical experience that using morning positioners has really been a big help for a lot of patients in maintaining their bites. You're still going to have bite changes, and they're going to be patients you're going to have to deal with, but there are certainly ways of dealing with those. I'm going to skip through this just because of time, but one thing that I think was interesting when I started in oral appliance therapy, when we first, I didn't start back in 1995, but when oral appliance therapy was first starting to be done on a larger scale for sleep-related disordered breathing, one of the first practice parameters papers stated that you could aggravate TM joint disorder, or you may even cause misalignment or discomfort. You need to be aware of that and be really careful when you are doing oral appliance therapy, because you may screw things up for the patient. They revamped those in 2005 and still said that oral appliances could aggravate the joint and may cause discomfort. So there wasn't much change there. In 2006, um, the feeling was that moderate to severe TMJ problems might be a contraindication for doing any oral appliance therapy for sleep related disorder breathing, which is, we found out by 2015 that TMD is not a contraindication. In fact, a lot of these patients got better. So the most common oral facial pain complaints that we see with patients is muscle myalgia. Most patients will come in due to just kind of undescribed facial pain that's related to muscles. It could be secondary to sleep-related bruxism or sleep-related disordered breathing. We have a lot of patients who may come in with disc displacements, popping of the jaws with reducing disc and non-reducing disc displacements. And then also just inflammation, just simple inflammation of the joint capsule. So if I look at a couple of case studies real quick, she's got a 43-year-old female patient who presents with facial pain, primarily on the right side. She's referred by her dentist. She's that suspected TMJ, and you'll have patients that will be referred to you if you start to incorporate oral facial pain treatment into your practice. Because, like I said, most dentists are just going to throw them in a night guard. That may aggravate the problem. That may do really nothing for them. But came in with with the pain. We did muscle palpation, found that she had some areas of discomfort in the muscles when we palpated them. Clinical impression was we suspected that there might be some sleep disorder breathing. And the reason was, I see this comes up. Yeah. So you look at the patient, got great teeth, everything looks great and fantastic, but then you see we got something going on here. Really heavily scalloped lateral borders of the tongue. The female, a very small, petite female, in her 40s. Snoring was present. We did find that out. We found that out through the sleep study, actually. But she came in primarily because of this oral facial pain. But we suspected sleep disorder breathing, so we had a sleep study run, and that's what we found. She had an AHI of 10.3, and that was what was actually related to the muscle myalgia. So an AHI of 10.3, but they were all hypopneas for the most part. So even patients with hypopneas she's probably doing a lot of clenching and grinding, a lot of tongue thrusting because of that scalloped tongue. So we knew that there were issues where she was overusing her muscles and causing this discomfort. Treat her for the obstructive sleep apnea, and what we end up with is a patient that's also pain-free from the oral facial pain complaints. These are common patients that you'll see in your practice. A 35-year-old female referred by the ENT because they suspect that she had some TMJ. She complained of ear pain. They found nothing wrong with her ears. So most of the time, the ENTs are going to refer those patients to you because, well, if it's not the ear, if there's nothing wrong with the ear, but that's where the pain is, it's got to be the joint. Yeah, she had some clicking and locking and limited mouth opening, headaches and all. She had been prescribed eating soft foods, a night guard, moist teeth, those kind of things by her dentist of record, but it didn't resolve anything. And then when she came in to see me initially, she was complaining of pretty severe pain, headaches in the range of 4, jaw pain 8, facial pain 8 out of 10. I mean, pretty severe. eights and nines, I mean, you expect most people to be in the hospital with that kind of pain. She was a new mom. She didn't sleep well. We talked to her, and yeah, we don't sleep well. So we referred her for a sleep. I remember when I told her, I said, I think you may have some sleep disorder breathing. I want to get a sleep evaluation. I remember her looking at me like I'd lost my mind. But again, very petite, 5'6", 135 pounds. We're not talking about an obese person. We're talking about a young female, no other signs or symptoms. We get her back. She's got an AHI of 18, an RDI of 25.8, and her oxygen desaturated down to 81 at night. So no wonder she was having headaches in the morning. She was having the pain because of all of this. So 18, here was her study. The oxygen nadir was down 81%. So we treat the obstructive sleep apnea with an oral appliance, advance her mandible, open up her airway, and her pain issues resolve. So you can see again, everything looks great. You wouldn't I mean, you would look at that and think there's no problem here. There's not anything. She really doesn't have bad scalloping or anything, but her other symptoms uh, indicated there was a problem. And when you look at her airway, she's a Mallampati 4. When she opens up, sticks her tongue out. I can't even push the base of her tongue down and see the lower border of her what am I trying to say? Her pharyngeal airway there. I can't see the border of it. So a lot of times that's what we see. Just in respect for time, I'm going to go through, get out of here this one, and I'm going to, because this was one that was treatment emergent patient. And what we found, it is interesting a little bit, because what we found was we started this guy. This was a pulmonary, pediatric pulmonology resident down at the university. He had sleep disorder breathing, got diagnosed with sleep apnea. We put him in an appliance, started him 50%, and he developed pain and couldn't figure out, that doesn't sound right. He just said, all my muscles in my face feel sore and tired. So I had him come in, we looked at him. What should I do? What would you do? Well, what I decided to do was I advanced the appliance, because I figured chances are it wasn't a joint problem when I palpated him. It was in his deep masseter where he had the most pain. I figured he's fighting the appliance. He still can't breathe. So we opened him up more. So long story short, we opened him up another 2 millimeters. He was sleeping a lot better. His pain went away. He was a little overweight, had a BMI of 33, but he went from a pre-treatment AHI of 20.3 and an oxygen nadir of 82 to, let's see if I can pull up he went down to an AHI of 4, and his oxygen got up to 89. Was the lowest it went was 89. So what they said was this is a significant improvement in comparison with earlier studies. So things can develop that you need to be aware of and be able to manage. There are a lot of programs, and I'm just listing some of the ones that I come up with that are available if you want to start getting more information about orofacial pain, TMD. Look these up. I don't think LSU still has their program. UCLA may not still have their program. Mayor and Terry Bennett have a great program. Jamison Spencer has a great program. These are great. Dr. Okeson's residency at the University of Kentucky is great for general knowledge. But if you want to understand how to incorporate it in clinical practice, Mayor or Jamison are great resources for that in their programs. I know Nearman Practice Management has a head and neck cadaver course, American Academy of Orofacial Pain, and recently, and I'll get to this, great book to get. Great reference source for you, Dr. Okerson's book on management of temporomandibular disorders and occlusion. Um, to summarize, with the shortage of DSM and oral appliance therapy providers, there's a critical shortage of orofacial pain and TMD providers. Accepting those patients will increase the number of obstructive sleep apnea patients that are diagnosed and treated. Education on orofacial pain is essential. So you need to seek out that training. I mean, without a doubt, oral facial pain and obstructive sleep apnea are fundamentally associated. And it can be segmentally added to as you become more proficient. Start out looking at treating, just muscle myalgia with oral appliances, or treating displacements with oral appliances. You may want to add in trigger point injections at some point after you get some training. They're even training now on introducing what's it called? Platelet enriched plasma enriched platelet therapy or injections into the joint for regeneration in the joint of the tissues and those kind of things. So it's if you provide that treatment, you're going to be able to treat more patients suffering from sleep-related disordered breathing, treating patients with TM joint disorders, trigger point. These are the ways you can add things in. Even there's a good friend of mine who practices in orofacial pain in Birmingham, and she and I have gone to several seminars on treating long COVID and vaccine injury patients that present with orofacial pain issues and headache. Headaches is another area that you may want to look into. So with that, I'm going to put that slide up for you, Eric, if you want to take it over, and we'll take questions if they got them.
Absolutely. Thank you so much, Dr. Blanton. I took a lot of notes during that. And if anyone has questions, please place them in the question and answer. Since I am hosting, I'll cheat and go first. Dr. Blanton, now that you've shown us how bruxism, muscle pain, and airway instability can overlap, what's one clinical sign that would make us pause and look deeper, or labeling someone as just TMJ or just sleep? What's that one sign?
I think questioning the patient. A lot of times patients come to the dentist, they're not necessarily going to be talking about their headaches. They're not going to be talking about necessarily pain in their face or above the neck, or about their sleep. It's all about, you got to ask the right questions. And the place for most patients, for most practices probably to start, is really educating the hygienists, because they're the first ones that see the patients. I don't know how many times I've had people just in general tell me that they don't remember their dentist's name, but they go to a practice because of their hygienist. So they have a much closer relationship with their hygienist most of the time than they do with their dentist nowadays. And hygienists are a great resource for having the time as they're, picking at people's teeth, to ask questions about, just things in general, about headaches, about sleep, about those kind of things, and kind of give the heads up. And then, of course, it's up to the dentist to come back in and follow up with those things. But I think the biggest point that I wanted to make, and I may have not done a great job about it, was that it seems like there's so often dentists get involved in oral appliance therapy for sleep apnea patients, and that's it's an easy track into doing something different in your practice and incorporating that in your practice, because it's dentistry. There's some medicine with it, but we all know how to take impressions. We all know how to have a lab make an appliance for us and deliver that appliance. So it's pretty straightforward and easy for the majority of people. The hard part is building that physician network and that sleep referral network. That's a huge part of making your practice successful and profitable in treating more and more patients. But What we don't recognize is, I bet you, at least, I don't have good statistics on it, but I guarantee you, the more you understand and study and understand oral facial pain, TMD, and start getting those patients referred to your office and asking for those referrals from your physician network, from your dental network, because most dentists don't want to deal with, is like you asked earlier, the heart patient is a lot of times that TMD patient. So a lot of dentists would refer to us because they didn't want to deal with the TMD patient. And what we found is, I bet you 80% or more of those patients turn out to be sleep patients. And that's what's the cause of their oral facial pain complaints. Yeah, sure, you're going to have some with disc disorders and those kind of things, and you'll have some weird ones. But the vast majority of those patients, it ends up being that it's related to their sleep disorder breathing issue, which again just opens the door for more referrals for treating patients that you feel comfortable treating with oral appliance therapy.
Absolutely. Absolutely. We've got a couple questions for you. So I'll start from the top. Does mandibular tori become a factor for sleep disordered breathing or sleep apnea?
I never saw it. I mean, anything that crowds the airway is going to be a problem. But in all the years that I practiced, I remember there's only one patient that I had to worry uh, about the tori. It was a palatal torus, because I was early in practice, maybe my second year in general practice. I wanted to make a denture for this guy, so I decided myself to remove his palatal tori. Big mistake, big huge mistake, because what I didn't do is I didn't make a surgical splint or stent for it, and trying to manage that, it was horrible. But anyway, I've never seen that really being an issue to where you would want to remove those or anything. A lot of the appliances now you are going to fit on the teeth. They're not going to be involved in that. But sure, that's got to be a problem for some people just in crowded airways. But
Absolutely. So I'm going to combo one. There was a comment made in the chat about, what about occlusion changes due to the mandibular device? And then that also kind of relates to another question. Do you worry about the morning bite can move the mandible back to a pathological or position in the morning in patients that has TMD or OSA?
well, no. Um, what all dentists are concerned about, I think, is maintaining the bite. Um, I'm I'm not sure exactly how they stated that question, but we did morning positioners on every patient, because we wanted them to have something to reestablish their bite. And again, the vast majority of patients that have pain are having the pain because of the sleep disorder breathing. If we can manage the sleep disorder breathing, the pain goes away. And again, I don't know the percentages. There's going to be some that's not going to be the case. They're going to have something else going on, but you can't bat 100% in this, and you should never give the patient the idea that you can. But that never was an issue. Using a morning positioner, I never experienced using a morning positioner as causing any problems.
I think they're more concerned about can it move the mandible back to the pathological position in the morning, so they're not going back. They're going back to where you don't want them to. Have you ever experienced that?
Well, there's really wouldn't be an issue. The issue that patients have, if it's a joint issue, is you got to understand the anatomy and remember the anatomy. If I move a patient, if this is forward and this is the disc and the condyle sitting here, and now when I bring them forward, I'm bringing them down and forward. If the disc is with the condyle, we're good. Let's say the disc is in front of the condyle, and when they open, it reduces, it pops, or it stays in front. When I bring them forward and down, now I've captured the disc when I'm in the appliance. When I push them back, there's nothing back here that I'm pushing. I'm not pushing them all the way back into the retrodiscal tissues. I'm just pushing them back to what their physiological position is now. So that really that really doesn't create an issue for them. And if they did, I'm sure it could happen to somebody, but I just never really experienced that pushing back to that was the condyle going back was not the pathology. The pathology was anterior to that. So
Absolutely.
that explains anything.
It did. That made sense to me. I think we're closing out now. I see one more question. So, given everything we now understand about how modern lifestyle and development are shaping airway and musculoskeletal system, what do you believe the future of evaluating oral facial pain will look like?
I hope that the future is it becomes more active. That more there's more opportunities for education to in order to uh, have practitioners educated. There are more programs that are being developed in some of the dental schools. And I wanted to mention, and I don't know how to throw it up here, I was going to, the American Academy of Dental Sleep Medicine is starting a new TMD program for dental sleep medicine practitioners. So if you go on the Academy of Dental Sleep Medicine website and look under their education options, there's a new program, and I'm trying to remember when the dates were on it. But there's actually going to be a cadaver part of it so that you can look at that. And again, so that you have a couple of options for looking. That was very helpful for me just because I'm more of a hands-on person to refresh my memory about the anatomy involved. It's also much more hands-on, clinical oriented type of thing, which is what it's great to understand and study and understand everything about the joint and oral facial pain and all that. But it's about how to incorporate that to where it can be practically managed in your practice in treating patients. So
Absolutely.
that's a good option to look at too.
The dental workshop you were just referring to, the American Academy of Dental Sleep Medicine, TMD for the DSM Dentist Workshop is Chicago, Illinois, February 28th to March 1st.
Yeah, and I mean they got some big names in there. I know Jeff Okeson is involved with that. Um, Mariana Millay, who is the director of oral facial pain program at the University of Minnesota, she's involved in that. But several other people, Steve Bender from down at the University of Texas, who's gone out through the Academy of Oral Facial Pain. These are all oral facial pain diplomats, and it should be a great program.
Absolutely. It looks fantastic. We have one last question for you. What are your thoughts on Botox for TMJ?
If I was a much younger person, I would have gotten into that. I would have gotten into the PFR and the PRP therapies. Botox, here's my thought about Botox. Botox is an option, but understand that Botox really is just kind of, in my opinion, this is totally my opinion, Botox is kind of a Band-Aid. What Botox does is it kills the nerve so you don't have the pain. It doesn't correct the problem. So every 3-4 months, once the Botox wears off, the nerve sensation regenerates, you're back with the problem. And then you've got to go get another treatment for the Botox. So Botox has a limited, Botox does not fix the problem. Botox can mask the problem and manage the problem, but it's a repeated type thing. The PFR, the PRP treatments where you take your own patient's own blood, centrifuge it down to the platelets, and the platelet the platelet-rich plasma injections back into the joint for people that have really chronic joint disorders. There's a lot of good evidence on that being very, very, very helpful. So that's an area that there's going to be, you're going to see more and more of that in the not too distant future.
Absolutely. We're starting to hear that more and more at the different conferences and courses that's starting to pop up. So definitely keep an eye on it. Well, that's all of our questions this evening. Dr. Blanton, thank you so much. We greatly appreciate you for joining us and sharing this wealth of knowledge that you have. You know, as you see on the screen, it's been up for a while. Our last day to receive cases is December 19th. That way they're back to you by the end of the year. We will be sending out dates for our January and the early Q1 webinars, podcasts that we're looking to getting into. And so thanks everyone for joining this evening. Dr. Blanton, again, thank you. If there's any way we can support you, please reach out to us at True Function. We'll have a lot of this posted on our website or our YouTube page following in the next 48 hours or so. And so if you have questions, reach out. So thank you so much again, Dr. Blanton. We'll look forward to everyone finishing out the year strong and having a great end of 2025 and beginning 2026. I am going to share with everyone who's still on the line. True Function is going to have a lot of really cool things coming out soon. I can't give you too many details, but just know there's a shadowy figure behind the scenes that is something we're working on with the FDA to hopefully launch at the beginning of next year. If you're interested, please shoot us an email or anything if you want to be a part of that. We are doing some clinical testing now, and hopefully we'll share more with you at the beginning of next year. I think Transform Symposium is in January, and that's when we'll be kind of highlighting and being able to show some people our new stuff that we're working on. So I'm really excited. So again, thank you all for joining. Dr. Blanton, it was a great pleasure. Thank you so much for sharing with us. Is there anything parting words from you, Dr. Blanton, that you want
to? I just hope, I felt so rushed. I just hope it wasn't too chaotic and that my primary point wasn't missed. And that is, if you're doing dental sleep medicine, you want to grow your dental sleep medicine practice, you want to treat more patients for their sleep disorder breathing, educate yourself on orofacial pain, TMD, and get comfortable requesting those patients to be treated, because like I said, the vast majority of them, you're going to find that their problems and issues are related to their sleep. And if you correct and manage their sleep disorder breathing, you're going to manage their pain. And the few that come in that you're totally baffled, you can always refer them. There's somebody you can refer them to, a pain management person or something, until you get comfortable. But just don't be scared. This joint and orofacial pain issues are not they're understandable if you put the effort in to understand them.
Absolutely. No, Dr. Blanton, you've shown us how sleep physiology and airway development, modern lifestyle, traditional TMD findings, they all overlap. Bruxing, all of this is some sort of overlapping, and we should definitely be looking beyond just treating with the device. There's the joint there. There's so many things, the pain, and they go hand in hand, as you very eloquently stated and showed clinicals for it. It's something that came across loud and clear, and your passion for it. So thank you again so much this evening. I really appreciate you joining. Thank you all for attending, and look for our website and email blast and socials for our next couple webinars. And hopefully you all have a great end of your year. Happy Christmas. Have a great Christmas. Happy New Year. And we'll see you in the new year. So thank you again. Thank you, Dr. Blanton.
All right. Thanks, Eric.
Thank you. Bye-bye, everybody.